let's start off with any particular people that had some questions.
My Zoom here.
Tucker, do you mind talking about your approach? So we talked about, the palatal configurations, who might do well with palatal surgery. How about those more tongue-based classifications and what you might or might not do in each of those cases?
So yeah, so over time I found that, okay, the more class A, which is the large lingual tonsils, at one point in time, I actually, if people had any sort of lingual tonsils that were present, I would actually go in and remove them, thinking that a little bit of benefit was good. Over time, when we kind of went back and looked at the data, I think that it was, at least in my relatively small group of people that had lingual tonsils that were kind of, let's say, on a scale of 4, there's the Friedman scaling, that if they had only moderate lingual tonsils, let's say a score of 2 out of 4, those people, they had a fair amount of morbidity associated with the lingual tonsils, and I didn't feel that it really helped them much. But I still consider the people that have lingual tonsils 3 and 4 to usually benefit from reducing those as part of the multi-level procedure. The thought before on the more class, the people that would be more B and C, initially my thought was, well, with more B, well, the problem is they get this big, massive amount of tongue volume there that if you could go in there and either reduce that volume with, some sort of partial glossectomy, or doing kind of a Stanford approach where you try to, pull it forward in some way. We did that for years. And short term, some of the results were maybe somewhat favorable, but over time, I really got the feeling that most of those people came back, with pretty significant residual disease over time. And so I really kind of lost enthusiasm for doing these really highly morbid sort of, big glossectomies, or even doing kind of the Stanford genioglossus advancement with osteotomies. And so, that group now probably is a group that may or may not be, benefited by doing things like nerve stimulation to help, open that up. But if I see somebody that's got pretty severe sleep apnea with a more class B sort of thing, I kind of say, well, you're best off probably right now with maxillofacial surgery or something. It'd be nice to have, lesser procedures, but I just, so I pretty much save the ENT surgeries for that group of people, that if somebody comes in and I've recommended maxillofacial surgery and they've seen the oral surgeon and they say, look, doc, I'm just not going to do that, and you're looking at trying to salvage the patient, well, then I would either consider something like a genioglossus advancement and or glossectomy. But I've really kind of reduced the number that I'm doing at that level. It's interesting, if you look at Stu Mackay's data from Australia, though, he's doing the less invasive kind of radiofrequency ablation. And certainly I'm sure he had people with this type of anatomy in that group. And so that may be something to consider, is doing more kind of just some radiofrequency ablation, which is a very low morbidity procedure. So that's probably would be my default for that patient, at least initially, and then maybe consider other treatments secondarily. For the more C, the thought was, would that be a group, since it's kind of retrohyoid, is that a group you should maybe do something like a hyoid advancement or suspension on? The question of that is, again, how sustainable that surgery is. If you do it with sutures, do the sutures break? And the answer is, I think, yes. And if you, pull it down to the larynx, does the larynx remodel? I think the answer is yes. And so I'm not sure what the right way to do with that is either. So I'll punt and say, we tried different things, but there's just not, I think we're just lacking on data to really guide us. So you have to use your just best. What the patient, I usually err on the side of going with procedures of lower morbidity now. I figure if I don't know which one is really more beneficial on the success side, I'll pick the one that's the least harm. That's kind of how I do it.
So Dr. Pinto had a particular question about phenotypes and mandibular advancement devices.
Dr. Woodson, hi.
Sure.
I'm one of the dental sleep medicine docs. And I wonder if you have any knowledge on the combination maybe of surgery in certain endotypes and mandibular devices. Is there any
Yeah,
data?
I don't have data on it, but I have opinions. So I'll give you my opinion. And that is, you know, when you look at the effectiveness of a device, and actually some of this I might be able to actually tease out through some studies we do during DICE. You know, when you pull the mandible forward, the big effect that it has in the retropalatal segment is on the stiffening of the lateral walls. And so that, you know, and you tend to not see so much movement of the anterior posterior segment of the palate. And so I've actually come to the belief that actually the people that have pretty serious vertically shaped palates, they technically don't do as well with oral devices as the people that have the more intermediate and obliquely shaped palates. That's my bias. Of course, that's also determined in part by how far somebody can protrude. So if you have somebody that has a 12 or 15 millimeter protrusive range, well, you're going to see a lot more effect on the airway than somebody that has a 2 millimeter protrusive range. So,
Sure.
so there's more factors than just the phenotypes. But if you actually during DICE, I'll actually get in there and I'll pull the jaw forward. I have a way of doing it during DICE. Some people will do what's called the Esmark maneuver, where they go behind the mandible and they push it forward. The problem with that is it does two things, or it does three things. Yes, it moves the jaw forward. Okay. It also rotates the head back, which we know head extension stiffens the airway and has a big effect. And then the last thing is that especially during sleep, it's like a sternal rub. I mean, you do the Esmark maneuver, it wakes the patient up and they arouse. And so I do a different way of trying to advance the jaw, and it's a little riskier. And that is, I got it from Ryan Seuss at Pittsburgh, but I
He has his fellow do it. He doesn't.
I know exactly. Yeah, it's like I try to. Yeah, exactly. But
I've been bit a few times.
Yeah, and you pull forward, and when I've done that during DICE, I really get the strong opinion that what I just told you is actually true, that the vertical phenotypes don't have as much retropalatal movement as the people that have intermediate and oblique phenotypes.
Thank
So
you.
that's, but again, it's not the only factor that's involved, but,
I want to piggyback on that real quick, just to pick your brain. There was a recent study that came out of Raj Dedia's study that showed that those who responded to mandibular advancement on DICE perhaps did not achieve as much success with hypoglossal neurostimulation, which is always, it's a little bit backwards from what I typically would have thought. And I was wondering what your thoughts are there.
Well, that's what I've kind of noticed clinically. Initially, people were thinking, well, we'll, do the kind of the Seuss maneuver, pull the jaw forward, and if you see good in a sense, I think the thought is that there was this linkage. If you're pulling the mandible forward, that you're pulling the tongue forward, and if you saw palate movement at the same time, that was showing that there was good palate tongue linkage. I think the problem is that the mechanism of mandibular advancement on the lateral pharyngeal walls is not just through movement of the tongue. That you're actually moving a lot of other structures from mylohyoid, pterygoids, the whole, it's doing a lot more than just moving the tongue forward. And so I think that, and what Raj's data is saying is not that it's necessarily worse, it's just not predictive. It's just, unfortunately, initially people were, and I was one of them, was saying, maybe this was a factor that we could use to pick out people that were good cranial nerve candidates. And it's just not, at least in Raj's data, showed that it wasn't the case. And that's been my case. Now, but again, maybe it's a matter of degree. Sometimes when you get out there and you pull, some people, they say before they bite you, you pull a little bit, and some people you pull a lot. But I think we do need some way to identify the people that I think have better tongue palate linkage for cranial nerve implant, because that's where the rubber hits the road. That's where the success or failure is not determined. When you stimulate the hypoglossal nerve, I haven't seen a tongue that doesn't move out of the way. I haven't seen one. It does. It does. The hypoglossal nerve implant, the stimulation does a great job of moving the tongue out of the way. I think it it fails pretty much on the lateral pharyngeal walls and the palate. And if we could identify those people that have a stronger linkage between tongue movement and pharyngeal movement, that would be a good thing. But I don't know how to do it. But you know, but I think that's what that don't you think that's what I think is that you know, does that help? That's my thoughts.
Yeah, this is Kingman Tucker.
Yeah.
So if I look at mandibular maxillary advancement and I say, okay, I'm looking from the inside out
Mm-hmm.
and saying that it works in sleep apnea because it does this. I see that it results in a posterior nasopharynx that is bigger.
Mm-hmm.
It results in a change in the oral pharynx that may or may not be relevant. I mean, I don't see anybody has done that. And so then I say, is there a way of achieving that without having to move both the mandible and the maxilla?
Yes.
That's
That's my question for 30 years. What are the elements that we need? Yeah. And so right now we're actually, Guy has submitted, we've submitted a grant that we're actually doing with Stanley Liu to actually, where he's doing some CFD and fluid tissue interactions proposed studies, looking at both dome and MMA, and really trying to identify, which are the elements that are important as far as flow goes. I think a lot of it's the lateral pharyngeal wall. We've done some work with mandibular advancement devices during DICE and stuff, and it seems to be that lateral pharyngeal wall stiffness seems to be, I think, really important as far as flow goes. And MMA does a very nice job of stiffening the lateral pharyngeal walls. I mean, yes, it makes the retropalatal space bigger, but it makes those lateral walls stiffer as well. And I think the real problem, even with expansion sphincterplasty, which is kind of really theoretically geared at that, when you actually look from a cross-sectional point of view, so if you look like with an axial CT scan and you look at like something like expansion sphincterplasty, okay, we're pulling out on the lateral pharyngeal wall, but if you actually looked at the lateral pharyngeal wall in a more coronal plane, when you're looking at the lateral pharyngeal walls like 10 or 12 or 14 centimeters in length, the expansion sphincterplasty that we do right now only affects 2, maybe 3 centimeters of that oropharyngeal lateral wall length. And so the rest of it is still highly compliant. And so the expansion sphincterplasty is only dealing with this really short, narrow segment of the airway. It's more than some of the older procedures did, but not nearly enough. And so then I actually think, well, geez, one of the reasons I actually do a hyoid suspension fake, I'll do sometimes there's a thing I call a temporary hyoid suspension, where I'll do during a drug-induced sleep endoscopy, actually do a small incision, and I have a little hook that I grab a hold of the hyoid bone and we pull it forward. And I actually like to quantify it a little bit better. It's not a very invasive procedure, but it allows you actually to see the effects of, let's say, hyoid position. And although it moves the tongue a little bit, I really get the feeling that it actually changes the lateral wall compliance, because as you pull the hyoid in different positions, the constrictor and all those muscles are attached to it. And I really think palatal pharyngitis, I think that it, may affect lateral wall compliance. And so when I see these difficult patients that have a lot, that's my kind of second go-to procedure now is to try to do something to suspend or to change the hyoid position. I'm not sure again, I think the problem is technically some of the things that sutures, if you pull it to the mandible, the sutures break if you pull it, but it's a fairly low morbidity procedure compared to other things that we do. And so that's been what I do, but I'd like to understand that the role of the hyoid more into how we can maybe surgically manipulate that to kind of help recreate some of the MMA effects. I wonder about that, as well as other ways to augment airway length, the effects of tracheal trug and tracheal traction. But, I don't know. I'm open to your thought. The reason I kind of wanted to actually present this is to get other people's thoughts on all of this as well.
So do we, I don't see Denise on right now, but
Mhm.
we've been thinking a lot, and she's been throwing me questions a lot about compliance and about this as well. I'll just make one statement though, is when we measured the force that genioglottal or that hypoglossal nerve stimulation produces in the forward force of the tongue, admittedly in an awake individual, but awake, upright, and supine,
Mhm.
it was almost 60 to 70% of maximal protrusive force.
Mhm.
So it's a fairly vigorous
Mhm.
resuscitation of the airway,
Mhm.
which doesn't tell us very much about what happens in what you're talking about.
Yeah.
So the issue becomes the compliance of the airway wall, the influence of muscle tone, and the relative but the overall picture really is comes from a position that airway health is an open airway at a very minimal energy cost.
Absolutely.
And so our when I look at a rabbit and try to make sleep apnea, you just can't do it very
Mhm.
easily. And other animals adjusted both probably the utility of however the neuromuscular control and configuration, but I'm really stuck on this idea that there is a configuration that permits the airway to stay open during sleep,
Mhm.
just as much as there's a configuration that allows you to speak, to swallow, and to do these other functions. And so the compliance, when we think of it, is, and so Denise is thinking about things like the stylopharyngeus,
Mhm.
which spans these segments and which
Mhm.
goes all the way down to the hyoid, and whether or not that particular tone of that muscle is lost, or the directional force of that muscle is lost, so that it requires it allows things to descend. So it's almost like an allowance more than a over time, and it's
Yeah.
really slow. It's slow. They got to that airway point it took a long time, and we want to fix it in like
Yeah, I know.
a couple days.
Well, actually, Tom Ferroa did. Part of his PhD thesis was looking at stylopharyngeus. Yeah.
Right.
I don't know. I don't think outside of the thesis, I don't think any part of it ever got published. Tom.
Yeah, I should ask him for his thesis. Right. I
Yeah,
don't think
yeah.
it did either.
But I think he had a lot of
It was
data.
goats. It was
Yeah, it was
goats.
goats. It was goats, and he looked at it during central apneas and during sleep and wake and different things. But the stylopharyngeus did act quite differently than other muscles, and not surprising because it's innervated differently. One other thing I've seen in the airway, though, I deleted this slide, is that when I described the phenotypes, we actually described the three different bundles of the palatal pharyngeus muscle.
Yeah.
There's the dorsal and ventral kind of vertical branches, but then there's a transverse bundle that actually is the passivans muscle. So when you swallow and you see this circular constriction of the airway, that's the transverse palatopharyngeus muscle, which is actually innervated by the glossopharyngeal nerve. And I've noted that during quiet wakefulness in sitting patients, when they breathe out, we'll see that. So during expiration, you'll see it contract. So that potentially, brings up the point of it could actually, during expiration, during sleep or other times, could this actually be involved in actually actively closing the airway? Since it's an expitorily active muscle, so it's like the I'm trying to think some of the other expiratory, the dog, not the transverse. I'm spacing out on the name of the expiratory constrictor muscles, and like the dog. But anyway, as you know, there's. But I wonder if it's actually it's not an inspiratory dilator, but actually an expiratory contractor muscle, and that could it actually play a role in some of these patients in setting a higher risk of having people with sleep apnea. one of the thoughts on an animal model for, I've always wondered about, I don't know if it's in any way feasible for things like rabbits and stuff, is the problem is they have the, the hyoids attached to the skull base.
Yeah, the
And-
rabbit's not. So that was why we
It's
kept
not,
it.
is it? But I wonder if the thing is, it's still, the larynx doesn't descend. And I wondered if you
Right.
could somehow take like the hyoid bone and suture it to the sternum in an infant rabbit. I don't know what you call an infant rabbit.
Right.
Uh,
Rabbitette. Yeah.
rabbitette. And over time with growth would you get some distraction of the airway where you actually would create an artificial pharynx by suturing the hyoid down to the sternum. So during growth, they would create a soft tissue pharynx. I don't know if that would happen or not, but I've never had the resources to do it.
Right. So the other is we dug into the literature that I was involved in, Sam Kuna was involved in the 80s to look at the contribution of these muscles to the compliance of the airway itself. And it turns out that the muscle tension under even with stimulation, doesn't really change the pressure volume characteristics of the mucosa because the muscles don't attach directly to that. Well, they do in the posterior wall, where the posterior constrictor is right there on the mucosa, but anteriorly, there's this potential space between the hyoid and the epiglottis. There's a potential space between many of these muscles, and the airway channel itself is quite indirect. And so the amount of tension you get in a muscle doesn't contribute a lot to compliance of the airway wall and those are studies that people have done in the arm and it's really the coordination of those muscles that position those muscles in a particular space. So when you move your arm, for instance, you don't have a lot of compliance when you look at it from that point of view, but to position your arm requires antagonist and agonist functions. And so we're going back into this ninth nerve and figuring out, it's coordination in the brainstem. So that was that's one of those things. If you had more money, that would be the key, is to find this airway opening.
Well, that's why I think initially when I looked at, years ago, I thought that compliance didn't play a role because I kind of said, well, geez, we know that muscle activity, opens the airway, and muscle activity doesn't change the compliance a great deal. So it must be changing the airway by changing airway size. And so we need procedures that then change airway size a lot, and not necessarily, but I think it's what you said, and that is that there's this whole role of agonist and antagonist, and so if you just look at a single muscle group, you may miss the fact that there's actually other things going on. The other is that one of the things that for Amy, she was asking about with different things for like hypoglossal nerve implants. I found that I think one of the things that's a real enemy of hypoglossal nerve implants, for example, is mouth opening, because as the mouth opens and the time that the lateral walls do become more compliant, and so any movement of the tongue just doesn't really have any effect whatsoever on these extrinsic structures, and that's the the real challenge, because it is the for most of these airway muscles that during arousals during sleep, we see somebody has an arousal during sleep, and we're looking either during sleep or DICE or whatever tools we're looking at, and it's still at this point I look at it and say, what are the actual, what exactly happened to open the airway, which muscles contracted, which structure changed, because I look as a surgeon, I say, well, if I could actually, what could I do to make that movement more effective, or to make it less necessary? And I still look at it and I'm confused. I look at it and I don't really, clearly understand all the.
So in the 80s, we used to we studied dogs supine anesthetized, but supine, and they would snore, and we would give them a respiratory stimulant and they wouldn't snore. So the idea is during anesthesia, under those conditions, the dog chose to snore. I mean, it chose from a neurologically and from a neuromechanical standpoint, it chose to snore. So that was when we tried putting negative pressure around the neck in a dog, and we could show that that improved upper airway, that they stopped snoring with negative pressure around. And so then it was and you're right, what muscles there make a choice to narrow, and then what muscles in this system make a choice to be activated. But we use things like nicotine and sodium cyanide and all sorts of
I know. It's like
respiratory stimulants that were just too much for everything.
Well, that's the question. I mean, right now, obviously, there's the drugs being developed to kind of medically treat sleep apnea, or at least to treat the AHI.
Right.
And I guess my feeling is that those, seem to have some effect. But I guess for me, maybe the direction of surgery is that, we have great thing, hypoglossal nerve implants, and we have Nyxoah coming in and some other devices. But, those are pretty involved therapies. But is really the future for apnea is to have some respiratory stimulants like you're talking about. They're actually a little less toxic than cyanide or strychnine or whatever else we used in those days. Have something a little less toxic, plus, a little more defined airway surgeries that actually can do a better job of reconstructing some of these characteristics. So you do minor surgery with the combination of respiratory medications.
What about myofunctional therapy?
I mean, that too. I mean, I actually think that there's a subgroup of people I am personally convinced with nerve implant that basically the nerve implant is acting as myofunctional therapy. It's basically, it's just a strengthening device. And because I'll have people that they have, the device is actually in no way timed with respiration. And you look at the sleep study numbers, and you have somebody that goes from an AHI from 50 to 5. And it just doesn't make a lot of sense that it's not working on a breath by breath, basis. And I'm thinking, is there some other process like muscle strengthening that's gone on? And it's just basically maybe just, the device is just exercising their muscles every night and keeping the airway open. And
it might be, but to me, it just matters that the airway is open at the onset of inspiration. If you get there by dilating it during expiration, that's okay. And it doesn't seem, if you're really fully have an airway that's obstructed, and you don't call it an apnea because it's no more than 10 seconds, but it generally doesn't open the airway.
No.
Even if it's
No,
stimulated.
exactly. That's the thing is I found with the right? I mean, the stimulator, if somebody has, it's got to keep the airway open. If it doesn't do a good job of reopening the airway, and I've tried to work with, people say, is there a way to actually improve its ability to open the airway by changing some stimulation parameters or doing other things? And to date, I've not been very successful in that. So it's kind of limited, it's got to be able to hold the airway open prior to inspiration, or else it's not good.
So we're thinking about, particularly the muscle, the myofunctional therapy doesn't really have a basic science to it. It's really what sticks, and trying to create an opportunity for equipoise somewhere other than does it work? Does this work or does that work? I think is the next statement. And then the other is,
Are you doing? I know Denise is real interested in the myofunctional therapy.
Yes.
Are you doing much? Are you doing much clinically though? I mean, my challenge is getting people to persist with it, you know, if they, you know, they,
Right. No, we haven't mainly because, well, we're stuck in, we'd like to make it part of a trial of some sort.
Mhm.
We like to make it all Zoom.
Mhm.
And so it can be delivered electronically, and it could be part of what, and but it probably needs to persist. Well, we're still haven't settled on what exercises are the most important.
Mhm.
But in the meantime, reviewing a lot of the activity that people did in the 70s, Guilleminault had some measurements of EMG activity. Other people have had some other thoughts about myofunctional therapy for speech, for palatal dysfunction. And the term, the palatal insufficiency, is used primarily for cleft palate, but it's really, or it's incompetence. Palatal incompetence is what they call it in cleft, but it's almost like it's a failure to remain open rather than a failure to close. And so thinking of it from the point of view of a failure to maintain opening, it becomes the interdependence between the tongue and the hard palate and the soft palate trying to lock it in place. And what tone is needed to lock that in place, and then on top of that, can you create tone and exercise tone? And does that really make a difference in the face of sleep having a general reduction in tonic and phasic activity in general? So there's, you know, because there are people that are quite fat, or there are people that have these unfavorable anatomic features and are breathing perfectly well at night. And maybe we haven't identified, we don't get those because they don't walk in the door asking for help.
No, that's the problem. What is I mean, one of the statements you made earlier was about, you know, the real goal is to actually, you know, to have a normal flow, in a sense, low pressure airway, you know, I mean, where you don't get the airway is really not made, you know, ideally made to handle, you know, these high negative pressure situations, you know, that, so what's the role? I mean, one of the issues with, you know, I've had, you know, with, you know, Peter Sestino did rapid maxillary expansion and things. And, you know, the question is, does rapid maxillary expansion, or like the dome procedure that people are doing now, does that, you know, how much does that affect the pharynx? Or, you know, where Peter would say, I think it works just because it makes the nose bigger.
Yeah, well, it makes the pressure drop is less.
Yeah.
And there's a pressure drop that needs to go down in to be able to expand the lungs. And just for those who don't know, the dome procedure is in people who have already closed their sutures, correct?
Yes, that's correct.
And so what they do is they open the sutures in your hard palate and expand that with the intent of expanding the area, at least the lateral area of the nasopharynx, and to what extent that also affects the positioning of muscles or the positioning of vectors of force for that.
Yeah, and it's interesting. I didn't. So the dome, they do it since it's a oral. You know, they put in a distractor in the palate to actually widen it, and it pretty much widens only the front of the palate. Actually, because they don't do much of the pterygoid, so that actually the choana themselves actually change very little. I didn't realize until recently. I thought it was actually more like RME, where it actually opened the whole width of the maxilla. The dome is pretty much an anterior procedure, so it doesn't affect the choana very much. So it's probably not going to have a big effect on the pharynx, and that raises the possibility of, you know, because they're seeing a fairly robust, you know, clinical response to the dome. I mean, it's not MMA sort of numbers, but it's pretty interesting, and it raises the possibility: are we just crappy nasal surgeons when it comes to sleep apnea, Amy? That's what I wonder. Is that do we need to look beyond what we're doing traditionally for the nose to look at things that we can actually, in a sense, change the nose and sleep apnea patients in ways that we've not done before. You know, where we can, you know, I mean, we don't want to like resect inferior turbinus, because then you get, you know, rhinitis sicca and empty nose syndromes. But what else, you know, can we do to actually really reduce nasal resistance
And increase that volume.
Yeah, and both from a flow effect, but then the second thing, Kingman, I have a question about, you know, years ago, McNichols and those guys, you know, over in Dublin did a whole bunch of studies looking at nasal afferents. And, you know,
Yes.
and, you know, David White, you know, the guys in Tool and stuff, have, you know, done a lot of work with the negative pressure reflex, dealing with the larynx. You know, it's kind of that epiglottic, supraglottic negative pressure reflex. But, you know, as a field, we've kind of forgotten about these nasal afferents. And
yeah, there are two things that we dug out. If you have people who are habitual mouth breathers and you bring them into the lab and you somehow make them breathe through their mouth, that over time their nasal resistance will fall. So there is so that's one. The other is that these things are local. I mean, we had done it not in people, but in dogs. The negative pressure in the nose increases more your alanase and less your genioglossus, but in the pharynx, it increases your genioglossus and not your alanase. So those flow receptors and those things are there. You could see it as a feedback loop, that if the less flow, the less open. But and we used to use multiple catheters with multiple pressure transducers, which are hard to buy these days. But I think that what we're looking at is it's sort of like trying to figure out diabetes when they already have a diabetic retinopathy and they already have renal failure. Is it trying to figure out the failure of the upper airway at a point in which a lot of things have now collapsed. And so the hypoglossal nerve stimulation has one segment in which you can sort of rehabilitate that with some extraordinary rehabilitative work, but the rest of it is trying to work. You know, you try to figure it out. I don't think you have to open the airway very much to have people breathing nicely during sleep. No. I mean, you don't have requirements for much. You know, your metabolism is less, your CO2 production is less, your breathing is less.
So it's interesting. Yeah, you'll see Damie will tell you know, when you go in and do DICE, you know, the thing that's amazing many times is that I will watch actually the people go to sleep, and as they're going off to sleep, it's amazing how small the airway can get in these apnea patients. As long as you're maintaining a low delta driving pressure across the airway. It's amazing how small the airway can get, and the patient seemingly has a pretty much normal minute ventilation or tidal volume or whatever you want to call it. It's just, and you're amazed. You just sit there and say, I can't believe that small airway is actually maintaining ventilation. So you're right. That's why, in a sense, you know, saying, well, geez, do we really have to do MMA, this massive procedure, to actually create that same state? And
so Wellman's trying to bring his stuff into the DICE. He's looking at a bunch of DICEs, I think, that are down in Boston University, because he doesn't have a great group there for things they're thinking about. And he's noticed he's now interested in this transition from wakefulness to anesthesia and the effect of why the jaw drops during anesthesia, and to what extent that also is a feature in an impaired airway. And they're going to try to recruit a bunch of healthy people and say, is this happening in healthy people? I mean, are there other reasons to do a DICE other than sleep apnea?
Not too many. Not too many.
No. But you know, maybe before certain other surgeries. I think that's what they're trying to do, is to get all their pressures and their videos and their endoscopy into an operating room for 10 minutes or so before somebody gets put to sleep.
Yeah, and I do that. I do a ton of nasal surgery under twilight sleep, under sedation. And in fact, a lot of my videos actually, and I don't have physiologic studies to go along with them, but I probably have, probably, I guess, in a sense, that when you think about it that way, I mean, they all have, in a sense, a lot of my patients have sleep disordered breathing, but a lot of them don't have much of any apnea, where I was actually just was doing the dice because they said, geez, we're going to the operating room and we're having your nasal surgery, why don't I take a scope and take a look and, just,
Right.
For background information. And so I do have not a lot of people that have totally normal sleep studies, but people that certainly fall in the range of more mild apnea.
Yeah, real mild. And I think, what is the minimal physiologic, bank that you could roll in and use? I think you have to see size, you have to see position, you have to see EMG activity in certain places, and you need to be able to measure flow and resistance, and to try to kind of figure out that in a fairly quick period of time before an operation is a challenge.
Yeah, some of it's like with the EMG doing, is there a way to get a good non-invasive like EMG, or like you do it either transmucosal or transcutaneous?
Yeah, we used
EMG.
to do it underneath the chin and get the geniohyoid, because it looked as though all the EMGs, I mean, even Alanase, well, Alanase is different. Alanase is more like your diaphragm and less like the genioglossus. But generally, all these upper airway muscles are going in the same direction during sleep.
Yeah.
They're reducing their tonic and their phasic activity. Denise has pointed out that the stylopharyngeus is one muscle that people have said remains active even if other air, but I said we got to repeat those studies, because those could be either error because you just didn't measure the right spot in what muscle, and you need to have a collection of things, but those all need to be repeated. I think the EMG activity and where you get to them, and some of them are very tough.
Yeah, it's a tough muscle to access. So
the tempo, the TVP is the other, tensor veli palatini, and its ability to move things laterally. So her interpretation of a lot of that stuff, of things collapsing in, is a lack of muscle tone, rather than a true, sort of like floppy tissue, fat flow into the airway, which I think is reasonable. I mean, we need another testable feature in here to complement what we're doing.
So I have a question on a somewhat related, but maybe different, on the EMG issues. One of the things, I mean, since I've come across this transverse palatal pharyngeus muscle, and I don't know if I can find my, I think I've got a picture of it just to give you let's see if I can throw it up here. I moved it out of my presentation. I usually make a junk series of slides here. Let's see if I can find the picture here. I may have.
Guys, we got all the fellows are still here with Amy.
Yeah.
Those are the groups. We were going to talk about the just noticeable difference in the Epworth Sleepiness Scale.
No.
This is much more interesting.
Yeah, actually I can't. Let's see, I'll try one more. Maybe if I can't find it, if it's not in this talk, I'll have to do it some other time. But
so you want to put a fine wire electrode into those things?
Well, I want to putting it's in the nasopharynx, and trying to put a fine wire electrode in this is going to be pretty much impossible. Yeah, I can't find it.
How about using one of those nasopharyngeal probes that they use for occipital epilepsy?
I'll have to look at it. So my thought is that if I had, just put a nasopharyngeal, not a nasogastric tube, it would be like a small, feeding tube type of arrangement with a couple of electrodes, one on each side of the muscle, that'd be touching it mucosally. You think that would
Sure.
be able to record enough activity?
Your surface electrodes of those things could be pretty good. I mean, what they have when they do epilepsy monitoring, at one time they used to have these long probes that they would put into the nose to be able to get close to the occipital lobe, because that's a relatively silent area for epilepsy. I'm sure it's fallen out of favor, but grass would have those, and they're sort of like, and well, they're the ones I remember were fairly soft.
Yeah.
And they had electrode tip at the end, and you really don't the precision can come later, but in order to sort of see, is there fish in that pond?
Yeah.
You'd be able to see whether or not it could be put in there.
Yeah. I'll look at that. That's good. I'll have to look it up.
And then you want to have something compared to what, right? Compared to what? And I do a submental EMG and just be able to say, is this going on? Or, the Alanase can be done with those electrodes they used to clip on the ear for ground.
Okay.
You can just take one of those and put it on the side of your nose, and you'll get your Alanase out of that. And that's, you can get respiratory drive out of the Alanase.
Yeah, it's how I mean, the Alanase is obviously a lot weaker than the diaphragm. Than the diaphragm, I would guess.
What do you mean weaker?
Well, as far as the sensitivity, the amount of respiratory drive needed to actually see a signal in there is a lot.
No, it's pretty good. It's really
it pretty good?
surprising. It's really surprising.
Because we used to, when I started in sleep, the lab that I worked with, actually, although they had some chest wall belts, they did almost all their drive measures with diaphragm EMG.
They put the two electrodes down below the costal margin. Those are tough because you fat and all those things.
But they were really good at it. They got really good recordings. In fact, it was amazing how well they did. They just were really, the neurologist that ran the lab, he got his people very, very skilled at it. And it was, I've never seen anybody replicate it, but he did a great job. But
well, you got to use, we started out that way when I was a fellow, and you would almost sand the skin, so you'd and you then be able to poke around to see whether it was the diaphragm or whether it was the lower intercostal muscles was never really clear, but it was just an idea of respiratory driving. And the Alanase is there too. The Alanase will be active even when the genioglossus is not in healthy people.
Well, that's why I said I haven't looked at that for a while, but that would be really interesting to look at. Maybe we should.
I had a paper on pre-activation of the upper airway muscles.
Yeah. And
then Sarat had one that scooped me because he could show that there are timing differences in the onset of an apnea. That I've shown that too in my slides. The timing is there, and that the Alanase though would diminish, but that the genioglossus would be gone by the time an obstructive apnea would start. And then as it went on, they would be recruiting, and the genioglossus would have a higher recruiting.
Yeah. One of the, again, similar, but the issue of the muscle activity, there's a phenomenon I've actually observed for a while called posterior tongue grooving. All right. And I don't know if I've shown you that slide.
Yeah, you've mentioned.
And it's a midline depression of the tongue that is definitely driven in part by the negative pressure reflex in the pharynx, because when you put a nasal pharyngeal airway in, it'll go away. It'll flatten out and go away. And it maintains this oral palatal interface.
When you say that, You mean that it allows the tongue to be up against the palate?
No, it does the opposite. It depresses the tongue away from the palate, so it
Yeah.
maintains an oral airway.
I see.
And if it's adequate, if
Oh.
it's strong enough, it seems to be, and there seems to be great variability in patients that have it. At one point, I thought that it was related to anatomy, that kind of people with bigger tongues would have bigger tongue grooves, but that doesn't seem to be the case. It seems to be because I do it now, probably in about 50% of my dices, I'll take a scope and actually look at patients, and some people tend to have a significant amount of grooving, and some people don't. So it seems to be not necessarily related to baseline anatomy. And the question is that I'm not quite sure how to describe it. I mean, it's this morphologic change in the airway, but
Is it present during paralysis?
I would have guessed that it's not. It's because I say it's an active neuromuscular
Right.
activity that occurs not with sleep onset. It actually occurs. It takes a while. So if you first look at it when somebody's going to sleep, the tongue is kind of in a passive state, and it's actually sitting up
Right.
against the
Okay.
palate. And then but if this was the back of the tongue, it's the middle fibers of the tongue that depress
Right.
down, and as the people work harder to breathe, this activation occurs, and it seems to be more tonic than phasic. In fact, it is tonic, not phasic. Although when you put the nasopharyngeal catheter in, the nasopharyngeal airway, and eliminate some of the obstruction, there go my dog,
Yeah.
is that they that this will go away as well.
I bet it's an expiratory. I bet it's an expiratory and maybe more tonic and inspiration, but that it's an expiratory reflex. You got to be careful about that, because it could be a lung volume or it could be active expiration.
But it seems to, what its purpose would be, theoretically, would be to kind of help maintain an oral airway, in situations of high levels of respiratory drive.
Well, the only person that I know that's at one time, I don't think he's doing it right now because it was tough, doing endoscopy in sleeping people was Wellman. It'd be interesting to see whether or not, I mean, it'd be hard for him to notice it from an oral airway because he was doing nasopharyngeal, he was doing nasal endoscopy to look at that.
Maybe actually, if I could do, because getting during DICEs, doing EMGs is hard, but maybe actually that would be the kind of way to look at it, is maybe try to get both the genioglossus and maybe the alanasa EMG, and actually looking to see if this is really related to some degree of ventilatory drive, and
it could be. I mean, the posterior tongue, in the rat at least, there is cross denervation of the right and left hypoglossal nerve to the back of the tongue, which is one reason for why the unilateral comes out straight to begin with and then deviates.
Okay.
And so there might be some heterogeneity of, if you put because you're talking about something that might even be intrinsic muscles in the tongue rather than extrinsic muscles.
Yeah, I mean, it could be intrinsic, although my guess is that it's genioglossus because it's so midline. But I guess my question is, in part, is that, I've observed this phenomenon. I don't, again, have a lot of normals to look at.
Right.
So I'm just looking at people with apnea. But, the question I have is that, does it have a role in sleep apnea? And what would that role be? Is it actually which gets into this whole issue then of what's the role of mouth breathing or not mouth breathing in sleep apnea, which is then two things. One is the issue of mouth breathing versus non-mouth breathing, which is nasal reflexes versus, do you have nasal afferents, non-nasal afferents, but also we always correlate frequently mouth breathing also with jaw opening, but they're actually really two different things. The jaw opening is results in a lot more different things than just simply mouth breathing. And so
I'm trying to channel my inner Denise on this stuff. And she's found the mouth breathing, nose breathing partitioning in sleep apnea, and shows that healthy people breathe through their nose 85% of the time, and sleep apnea during wakefulness, and then sleep apnea patients breathe through their mouth 65% of the time during wakefulness.
Yeah. And so I always tell my fellows when we're reading sleep studies, I mean, a lot of times we'll see, when we look at nasal or oral airflow and you see these kind of quote hypopneas, you see a decrease in nasal pressure signals. And I tell them, I think a lot of times that's just mouth breathing. People are mouth breathing. But I tell them, I think mouth breathing during sleep is abnormal.
Yeah.
I think that's a sign of some sort of an abnormality idea. My thought is that it's a sign of increased airway resistance and or increased work of breathing.
But sometimes it doesn't even happen with work of breathing. I mean, the mouth breathing, nose breathing literature is dominated by exercise. And when do you make that transition between nasal breathing and oral breathing, and how do you do that? But as you're going to sleep, I guess that would be is to compare exercise transition to sleep transition.
Mm-hmm.
But but the idea is that during sleep, I think it's an incompetence of your nasal pharynx. I think that's the example.
Well, there's two kind of oral breathing, I think, in apnea patients that I've seen, at least when I'm watching people sleep, and that is, there's the one group of people that as they go to sleep actually will open their mouth, and actually it's actually part of their maintaining of ventilation. Then there's a second group where the oral breathing is a response to the apnea. So I would say that to the point that I would say that almost every not obstructive hypopneas, but every obstructive apnea ends in a mouth breathing episode. Right. That's how mouth breathing is the drowning escape route. So if you think of an apnea as a drowning event, people escape from drowning by mouth breathing. So if you hold your breath underwater, you don't come out and breathe gently through your nose. No, you open your mouth awake with this low resistance, all your muscles are activated, and you go, and so there's
That's always told me that the muscles that produce an obstruction are not the same that break an obstruction, because it's not just the reverse of that. And so I'm not paying any more attention to how you get out of that. Let me ask a related curiosity, we haven't had the fellows ask. How do you handle dry mouth on CPAP, or even on CPAP?
I do pretty much like everyone else, and that is that you chin straps, you try humidification. I mean, you try if somebody's got a significant nasal abnormality, that might help them use a nasal mask versus a full face mask. One of the challenges is I think a lot of people don't realize, and I think in sleep we do, and that is that during sleep, saliva production goes down quite dramatically.
Right.
And so a lot of times people get dry mouth even when they're not respiring through their mouth. I think if you just held your mouth open, even if your pharynx is blocked off, you might even be on CPAP, nasal breathing. But if your mouth is open, it's going to very quickly, dry out.
We're working on mouth tape, on just a piece of tape to hold the vertical dimensions, not horizontal. It's not, and it's the paper tape. And I've been surprised at how it works, just to keep your lips approximated. It's not to be a seal. It's not a duct tape. And you can open up your mouth pretty easily, because so it's not as though it gets to people.
Probably makes sense. I mean, I just actually had a patient yesterday talking about some paper tape on their mouth and it clearly can't seal it. But, think about it, right? Now we're all wearing the masks outside. I mean, it's like you know, here in Milwaukee, I was saying earlier, it was like -8 when I woke up.
Right.
But you go outside with them, you know, after you're in the hospital, I wear the mask till I get to my car, and usually, but I find that, yeah, it's actually, I may start, you know, when cold, dry weather, you continue using the mask because obviously it does preserve the humidity, and, you know, so that, you know, big role of the nose is not just heat, but moisture conservation. And by putting a piece of tape, you know, in front of there, creating some
Well, maybe we
expiratory.
could just put a mask. I mean, not over your nose, but underneath your CPAP.
Yeah,
So
that's
that,
actually good. Just,
that's a good idea.
yeah,
That's
I mean,
the Tucker Arabesque.
man, we're gonna patent this, Kingman. Everybody's, you're gonna get your NDA here in a minute. You know, but probably just, you know, maybe even like just like a surgical mask.
Yeah,
you
just
know,
something
just
simple.
take it, just
Yeah,
put it,
right.
yeah. That's
There we go, guys.
right.
We'll deploy that with our fellows in the next. And
I remember it's got to be
drive the
named.
faculty crazy. It'll drive. I love it. Anything
gonna-
to drive the faculty crazy.
We'll call it. We got to name it something. No, it's got.
Oh yeah, but no, it's just the Arabesque. So the fellows have questions here because I've been.
And there's time.
You got some time?
I got time, yeah. So I
Okay.
see actually that there's some chat stuff on there.
Okay. No, they're just saying hello. They think
Okay, thanks.
they're you know they're making your ears burn. That's good.
Okay.
Zach or Anupam or Omar Maduri. Oh,
I
So
think
where
you
would you-
asked all the questions, Dr. Stroll.
what? Well, you've heard me talk, so you know. So I tried to see if we could poke holes in what I usually say.
I mean,
So the-
whatever we can think of, you've already you're on it.
Yeah, yeah.
So the question is, you know, for me on the, you know, it still gets down to on the surgical side, wanting to say, you know, what are the ways to actually condense a MMA into something that's more manageable, you know, that
Yeah.
where you can affect what the critical characteristics, you know, of the airway, so we can again maintain normal ventilation without abnormal ventilatory drive.
So
or
I
whatever.
think that really demands a more basic science on. You know, I like what you're doing with the trying to model things and trying to understand those sorts of things. I had a couple grants I put forward to try to do that from a mechanical with biomedical modeling, and it got nowhere because I didn't understand.
Well, and even like when you try to diagram it out, I mean, trying to come up with, you know, in a sense, just a simple on paper model of how to take a conduit and say, how do you add these different elements and try to break them down into individual evaluatable characteristics, you know, you know, you try to take it, and so it's not just one big black box, but you try to divide it into different elements. It's hard to make sense out of it all. It's just
So we're going to start some MRI measures of using the negative pressure around the neck.
Mm-hmm.
And in the midst of those MRI, dynamic MRI, and when we're able to, they don't want me to do it, is to use CPAP and then quickly, you know, pop the bubble and see what happens on the closure side of things. But the other little part of it is we were able to get them to have a swallow in the MRI as a vent, a dry swallow to begin with, that will be the sort of the warm-up act for taking the image. But really, we're interested. We say it's not going to be any different between OSA and healthy people, but on the other hand, we think it will be, and so we're going to probe that. But it's another way of having the airway close and reopen is to swallow. So that's how I'm thinking about it. So if the coordination looks different on a fast MRI, then maybe there's something that to think about.
Well, you're probably aware. I mean, as you know, I mean, clinically, there's, you know, we certainly noticed it in surgery that post-surgery there's abnormalities in swallowing, but then people started looking at people before and after surgery, and they've found that there's clear abnormalities in swallowing in apnea patients.
Right. No, we
as a
got that
baseline, yeah.
we got that literature, but it's but why and what's the, to be more detailed into the, again, this coordination of a mechanical device. It's not just the, I mean, you should be able to adjust. Well, you
Mhm.
should be, but you can adjust your neural output to overcome mechanical
Mhm.
challenges. I mean, you sound the same in your voice standing up or lying down on your back.
Mhm.
And that takes a tremendous amount of adjustments of muscles
Mhm.
and to make that resonator sound the
Mhm.
same.
Yeah.
And that you would do that without even knowing you do that.
Yes.
I mean, you because it's important for
Sure.
you to sound the same, right?
Yeah.
Because that's who you are. If you're lying down, you don't want to sound like, Mickey Mouse, or you don't want to sound
Yeah.
like
Sure.
something different. So I think that there's a lot of capacity in that brainstem coordination, which may be lost, and maybe not lost, but maybe either
Yeah.
because
Dysfunctional.
coordination in playing a piano requires practice.
Yeah.
Coordination in terms of doing very complex things with fine muscles requires practice. So I think, and then we want to go on and try to figure out people who don't have sleep apnea that have the same sort of, we don't call them risk factors. Well, they're risk factors, but we don't call them causal pathways. So they may be obese, but they don't have a causal pathway of either anatomy or loop gain or
Mhm.
EMG activity or those sorts of things.
Mm.
So we make that distinction. I mean, they're equally obese when they're awake as when they're asleep. They're equally a male when they're awake and when they're asleep. They're equally this way, So we're just trying to say, I don't want to hear that anymore.
Yeah. Well, it's and you're right in the sense that you'll see severe apnea patients have what I say even during either drug induced or normal sleep periods of time of prolonged, very normal breathing,
Right.
and then something seemingly mild changes, some minimal sort of thing happens, and suddenly, you just get into this, horrible.
Magni Yunus pointed that out. I don't know, to me at least. That was the earliest thing. He had a series of 8 or 9 PSGs in which people were breathing completely irregularly, and then without a change in position, without a change in sleep state, without a change in EEG, without a change in anything else, they all of a sudden started to get into repetitive apnea.
And once you get into that system of repetitive apneas, and you have the overshoot and the undershoot, then you get into these things where it's not a minor, then it's no longer a minor change. You're looking at massive changes in the airway, but there clearly is, at some point, we're actually doing right now a study with a little elastic tongue implant, called LinguaFlex, and it's an FDA trial right now. And it applies 50, less than 50 grams of force to the tongue. And in some people has a real dramatic effect on apnea and snoring and quality of sleep. And
where's it put? Is it put in the tongue?
It's put in the tongue. It transverses, goes from the frenulum back to the dorsum of the tongue. So it's actually, it's replaceable. The advantage of this compared to other tongue suspensions is that it's replaceable, but it's called LinguaFlex.
Remember they had that bolt. They used to have that bolt that you would put through your tongue. You don't do that anymore.
Yeah, no, so they've kind of fallen out of favor, but also those they broke and they pulled through and they didn't last. So the idea of this is that it's replaceable. So, it's not going to fracture or break. But it also applies very little force. And for the life of me, I'm not sure the mechanism of how this thing is doing its work. I mean, I've got different theories, but to actually really understand precisely how it's working, and the company unfortunately didn't do those studies before going to clinical trials, which I would have done, but they but it's a transition, but it's a very small, So things you don't necessarily have to apply, like I say, you don't necessarily have to do
Yeah.
the MMA
Yeah.
to make the
Yeah.
airway stable. And,
So how does it attach in the back, or does it sort
It's
of
a little- it's a
phalange
little-
out in the back?
there's a button or flange in the back, and then there's a flange in the front. So it's actually with little knobs, and you can adjust the tension. So you adjust it in the front, but there's two little buttons on it. So the one on the back it's a single unit. So the only adjustable one's in the front. But you basically put it in. You take what it basically looks like a spinal needle under some twilight sleep,
Right.
and you go
Right.
through the frenulum, back out the foramen cecum. So it's actually high up in the tongue. It's not down low in the tongue.
Right.
And you come out at the foramen cecum, and then you grab the thread with the little needle, and you pull the thread and the anchor in, and the elastic thing. It's only it's
Right,
very
right,
relatively
right.
short,
Right.
and so the procedure takes, in an ideal situation, takes 1 minute to put in,
Right.
and then, like I say, we're doing this study now. Clinically, the people, people are coming back and they say, geez, my bed partner's thrilled. I'm not snoring anymore. I
Right.
think that we'll see on the AHI numbers as time goes
Yeah,
on.
right, right.
But,
But if you had that, and how much elastic modulus there is, I guess if you were lying on your back, it would stretch and would create more tension.
yes, that's
And then
right.
if you were sitting up, it would get shorter and wouldn't give you a
Have much
problem.
tension, yeah. So exactly, we haven't measured it. They haven't measured the tension. So that's my thought, is that there's actually more tension on it during sleep than what we're measuring during wake. And it's actually acting to kind of prevent the tongue from rolling back into the airway.
I
But
would think you'd have positional stuff happening.
yeah, we'll see. I mean,
Yeah.
it's a surprisingly minimally invasive sort of, and whatever it's doing in the airway is not this huge, massive,
Right.
restructuring the airway.
Right. Well, I
But,
think that we're going to be looking at this, the Sometrics negative pressure around the neck is going to go into a clinical trial this year,
Yeah.
second quarter probably.
Well, it's interesting to talk about the issue of some of with swallowing and the different timing of the different reflexes, because maybe a device like we're talking about, the LinguFlex, by providing a certain type of force to a certain group of muscles, makes up for
Proprioceptive,
certain,
yeah.
it does
Yeah.
other that I wonder if it's doing other things that are distinct from just the mechanical effects of keeping the tongue from falling back.
Yeah, it's hard because you do adapt to any afferent system. You can adapt and adjustable, and it's plastic in both ways, both beneficial and abnormal.
Yeah. So we'll see. It'd be interesting to go forward. So, well, I'll let people go back to their tasks. I
Okay.
guess I don't know what
All right.
time.
Well, thanks a lot. Thanks for staying on with us.